Hello, NeuFit Nation, and welcome to episode 100 of the Undercurrent podcast. It's a major milestone on this journey here, and it's been a wonderful opportunity to look back and reflect on all the wonderful conversations and topics we've covered in the first 100 episodes. And to celebrate, I wanted to go back through and do some recap episodes where in this episode 100 part 1, we're going to go back and pull out some of the most impactful clinical insights that have come up in these first 100 episodes so far. And then in part 2 and part 3, we're going to do the same with business related insights and discussions. And then finally in part 3 with more of the topics related to personal development, leadership, and mindset. So I hope you enjoy these recap episodes. We're going to have little snippets, anywhere from 2 to 5 minutes in length from some of the highlights of these episodes here. And I challenged myself to pick out the top 5. In this episode, part 1, I'm going to pull clips from 7 episodes because I thought it helped us weave together a little more of a cohesive review. And we can go now to the first clip. The first clip is from back in episode 10 when my guest was Michele Harris. She's a physical therapist and co-founder, co-owner of CHARM, the Center for Healing and Regenerative Medicine here in Austin. And in this episode and in this clip, she talks about their approach where they're using stem cells and exosomes and these regenerative treatments to take care of the hardware, and then where this software-based approach of using the Neubie and neuromuscular reeducation, how important it is and where it fits in. And I really like the way that she frames up the idea of working with both the hardware and software. So we can go to that clip from Michele Harris.
Yeah, I mean, it was kind of one of those things where there was a gap, right? Mm-hmm. So we get a very diverse population at CHARM. We get a lot of people who have been in pain a long time. We get a lot of people who maybe had surgery and are still in pain. We get a lot of people with just degenerative joint disease and or a nasty tear that they'd really like to not or to avoid surgery. And so the structure piece, like you said, is just that, the regenerative medicine. But just because you affect and improve the structural integrity of a joint doesn't mean that miraculously those compensatory movement patterns or dysfunctional firing patterns just get better. Mm-hmm. Certainly a stable joint is required for that, and that structural piece is really important. But many times the neurological and neuromuscular dysfunction is what led to the degenerative joint disease or that tear to begin with. Mm-hmm. And so just because you fix that structure doesn't mean that it goes away. And there was a gap because I couldn't, in a lot of our patients, I just couldn't decrease that global muscle upregulation. I couldn't tease away the compensatory movement patterns with just what I had with my hands and some pieces of equipment and some other neuromuscularly based therapy strategies.
Since you've been using it then, are there any interesting outcomes or particular patients or scenarios that come to mind where it's been particularly impactful?
Wow. That's a really loaded question. I think again, the sympathetic downregulation piece has been pretty profound. Mm-hmm. Since our patient population is, I think by definition, because there's pain involved and at times there's been long-term pain involved, there's sympathetic upregulation involved. Mm-hmm. And that alone has been very helpful. Yeah, some really interesting stuff, sleeping better, my digestion's better. I mean, all of these strange things that people can barely put their finger on, mm-hmm. but know that they want to do it when they come back in. Don't take that piece away. And it's like, okay, 10 minutes. The other piece is just the ability to scan and be very, very precise with where we're going to put the electrodes to load this system during the activities, whether we're on the NEURAC or not, mm-hmm. Has been super helpful. And we just, the NEURAC brings with it very rapid change at times. And I feel like the Neubie has just taken that up a notch or two. And the other piece is the ability to just lengthen and relax those muscles. Whereas working in the red cord does make people more relaxed because you're getting the right neuromuscular input and the right coordination, and people will step off of there with feeling, oh my gosh, my hip is so much looser.
Yeah.
But the combination again has just been, it's just a really powerful combination. And again, it's the diagnostic in addition to the therapeutic benefit of it. The other piece is we have a big population of EDS patients. It was so funny that you mentioned that on the mastermind call, because it's like, we have so many EDS patients in our practice.
Just for everyone listening, Ehlers-Danlos syndrome.
Ehlers-Danlos is a hypermobility of the connective tissue, which it just screams, I need regenerative medicine, right? Because it's white tissue and it needs to be more stable. But it's also because, by definition, this individual's connective tissue is unstable. We want to try to make that neuromuscular system more stable.
All the more important.
Yeah. And I have had such good results with the EDS population. Mostly young girls, it seems like, have EDS. They tend to be really beautiful dancers and really good swimmers and just have connective tissue that's super duper laxed. But with laxed connective tissue, you then have a neuromuscular system that's trying to basically hold you together. Yeah. And so the combination of using the Neubie to kind of relax where we want certain muscles to relax, but then use it to just truly improve the neuromuscular tone around really laxed joints has been very interesting.
I hope you enjoyed that clip. Now we're going to go a little more deeply into the control of the brain and nervous system, the control that the brain and nervous system exert on movement and how that relates to preventing or causing injury and ultimately performance and everything that we do. So this is a little bit of a deeper dive into how the brain controls movement, back from episode 51 with Dr. John Marchese, who's a chiropractor in the Boston area specializing in functional neurology. Here's the clip from the episode with Dr. John. How many of your, quote unquote, simple orthopedic patients, like you mentioned this, post-op hip replacement woman. So, for example, how many of your, quote unquote, just, typical orthopedic pain patients come in, have findings on a neurological assessment or neurological evaluation that are directly impacting their pain and orthopedic issue?
100%. Legitimate 100%. You can't throw a person in here into this practice and not have us find something that would directly impact it, because there's nothing in the body that isn't impacted by the brain. And, is there such a thing as a simple orthopedic problem? So I love it when people come in and say, well, I jumped up, I went to head the soccer ball, I came down, and my right ACL ruptured. Okay, well, why did your right ACL rupture? Why didn't your left ACL rupture? We already have a complicated neurological picture going on right there. Well, did you land more on your right leg? Did you land more on your left leg? It doesn't matter, because predictability of injury is neurological, because your neurological pattern or the neurological pathways that you utilize the most are the ones that are going to dictate what happens to you. I mean, everyone's trying to predict injury, right? Ever since they came out with the FSM, right? I can't remember the name of the guy who came out with it a long time ago, right? Ever since then, they've been trying to predict injury. And ever since then, as far as I can tell, injuries have gone up. We have endemic hamstring injuries, endemic ACL injuries, endemic everything. Because listen, I have a small practice, right? I like to say I'm a bit of a ham and egger, which means that essentially I see my patients and that's it. I'm not affiliated with universities or anything like that. But for God's sakes, would somebody please do a neurological evaluation with the predictability model for non-contact injuries and repetitive injuries? Because somebody's going to do it. Because as far as I'm concerned, that's the missing link, is the neurological profile of an athlete gives you the predictability for their injury. And that's it.
So if someone were to do that, do you have a hypothesis on
what would stand out the most in terms of what, if any, particular deficits might lead to certain injuries, or would it be a range of certain things? I mean, what do you hypothesize would happen in a study like that?
Well, I'm more of a cerebellum fan. I know some people have their favorite parts of the brain. My favorite part is definitely the cerebellum, which is in other circles would be pretty goofy for someone to say you have a really favorite part of the brain, because the cerebellum is, like that big, and the rest of the cortex and neuraxis is much, much larger, but yet the cerebellum has more cells. Would that then tended to be more important? The cerebellum has almost 4 times input towards the cerebellum as it does output from the cerebellum. So it's always listening, it's always gathering information, and it basically makes us athletic as far as I'm concerned, and probably as far as a lot of other people are concerned. So I would look towards a cerebellar examination and then get a formatted, I guess you could say, evaluation where that we can test for tonal output to the posterior chain, anterior chain, et cetera, and whether there are feedback, feed forward, efferent copy type issues going on with the cerebellum. If I know a movement and I go to perform a movement, then it should happen the way it was programmed into my brain, with the communication between the frontal cortices as well as the cerebellum. So that should happen. But why all of a sudden doesn't it happen? And why all of a sudden does a person step, turn their head, and blow their ACL? Why does a person step, get a rebound, turn their head, and rupture their Achilles? Little things like that. So if I look at the neurological evaluation, right, and I look at the downregulation of the brain and what it's supposed to be doing to our, let's say, ventral horn, where you send a message down, crosses over, hits the ventral horn, goes into the end organ. And if that end organ is a muscle and it has to respond quickly, so if I step and I move, and my hamstring is supposed to go ahead and fire with my quadricep, push me off into a particular direction, why is it that that hamstring would go ahead and fail and allow for that anterior translation of the tibia to blow the ACL? Well, if we look at some of our neurological evaluation predictive modeling, if we have a reduction in, let's say, neocortical activity on one side of my brain, okay, neocortical frontal structures, some parietal structures, et cetera, things that make us human, I can have a reduction in volitional activity on the opposite side of my body.
Now we'll transition to our next clip. This is from episode 66 with Logan Cooper, physical therapist who is, among other things, the co-chair of the manual therapy curriculum in the Osteopathic School of Medicine at Michigan State University. So he has these very sophisticated manual therapy treatments and techniques, and he talks generally about how he approaches manual therapy and how the Neubie can complement that. And then also very specifically, now we're going to also start going down into a few different conditions and sets of circumstances, because he's going to talk about one of his specialties, which is chronic headaches, face pain, jaw pain, and he's going to talk a little bit about how he treats those as well, to give us examples of what leading clinicians are doing out there in the world. So here's the next clip from episode 66 with Logan Cooper.
Most of the time, people are coming to me because of some kind of injury. The nervous system has a few responses. It can turn muscles extra on to kind of protectively splint an area from moving because it doesn't want to hurt. It can turn other muscles extra off so they're not pulling on that threatened area. And it can create pain. So those 3 things. Pain is always an output. It's always a response. Muscles turning extra on or muscles turning extra off, regardless of the distribution of those 3 things, and often all 3 happen together, the area where that threat has come in, the sensitivity, the threshold gets lowered. The nervous system is extra sensitive at that area. And the way that I approach things is I try and restore the mechanics to offload the threatened area, and then use the Neubie to find exactly where that threat is coming in and raise the threshold so it's not as sensitive. And that sequence tends to just work phenomenally well, especially in people. The majority of people I see have been in pain for 5, 10, 20 years. It's like almost a lifetime. So their nervous system has learned to maintain this. They've had homunculus smudging. So they've had literally changes in their brain that have been made over this course of time. And this allows us to wake those brain centers back up and redefine these areas that have been just smudged and unclear for so long. And just changing the mechanics doesn't always affect that neurology. So that combination has been key. I first start with getting everything as back into as postural balance as possible with the manual therapy and the mechanics. And then I'll get into more kind of head and face mapping with the Neubie. And this is something that I've just kind of come up with and explored. Again, it's a manipulation of the general principles of mapping that we would do throughout the whole rest of the body, right? So I'll go through and do the typical mapping process through the arms, the upper quarter, that kind of thing. But then if you think about the trigeminal nerve and its communication through the upper cervical spine, so the trigeminal cervical nucleus and all its communications into the C1, 2, and 3 region, there's a big influence from that. So the trigeminal nerve talks to the nuclei in that region, then it goes up, it ascends through the trigeminothalamic tract up into the brain. So that's why neck pain can sometimes refer as, or neck issues can sometimes refer as head and face pain. The trigeminal nerve is going to do sensory. It has 3 branches, primarily to the forehead, under the eye, and then along the jaw. But then it can sometimes have referred pain to that region from that upper part of the neck. If there's a neck component to someone's headache, this has been just game changing because it allows us to take that neurology and downregulate that threat from a way that just hasn't been done before. So I'll go through and treat out the mechanics, and then I'll have the red pad, or kind of that grounding pad, on the upper part of the cervical spine, horizontally, so it covers that C1, 2, 3. And then I'll have the small sponge and small electrode going around, and I'll basically map the face. And I'm only looking for the very onset of the sensation of the stimulation. If you've ever done this on somebody's face or your own, you get to certain regions and it can be a very, very sharp kind of sensation. So I'm not looking for that at all. I just want that initial onset. And then I treat it a lot like we would through our normal mapping and then treatment process.
Now we're going to transition to another episode, and this is actually with Logan's co-chair at that Michigan State University Osteopathic School of Medicine that I mentioned earlier. This is Lisa Chase, a fellow physical therapist, and this is from back on episode 55. So Lisa has a fascinating background. She was actually the physical therapist for the women's tennis tour and has done this instruction at Michigan State, now has a private practice in St. Petersburg, Florida. And in this clip, she talks similarly about how the Neubie fits in with some of these other techniques that she's using, and how using neuromuscular education of the Neubie can complement these other more sophisticated techniques here, and the way that everything fits together. I think it's a beautiful description, and I hope you enjoy this clip from episode 55.
Muscle energy is an amazing tool that really it switches the nervous system. So it's looking for a segmental dysfunction somewhere along the spine. It could be in the pelvis. It can be in the extremities. So you're looking at the muscles that are attaching around that joint, and you are working within the bind and ease of that joint and the muscles that attach to it, and being able to just give very gentle muscle relaxation types of cues to the patient. And then you move to the next barrier. And even my clients that come in, they all kind of know how I do my assessment. And they're like, what is this? This is just, I've never had this before. It's just unbelievable how, you just do like the littlest thing and all of a sudden I can move again. So it's super powerful. Definitely the making the diagnosis and figuring out what is the best level to address. And then as soon as you do that and you work with the muscles, which ultimately are working with the nervous system, it flips that switch. People can move again. We get muscles that are inhibited to now fire, and muscles that have too much tone to quiet down. So I combine that with looking at how people move in various different, directions. And then I look at how the joint mobility at the different joints. So is there something that is restricted? Once I kind of hone in on the main areas and figuring out, is it truly a mobility issue or is it a stability issue? Because if it's a stability issue, I'm going to go down a different road. So I like kind of determining, okay, if it's mobility, then I'm going to mobility test the areas that I anticipate to be restricted. And part of my assessment is looking at the firing patterns and the movement patterns of different muscles. So say, for example, glute max, just looking at the overall firing, not just is the glute max firing, but looking at the overall pattern. And then if that is a dysfunctional pattern, then looking at what could inhibit the glute. Is it, a hyperactive hip flexor or tight anterior capsule? Is it L5S1? Is it, something, sometimes it could be something in the viscera that can be restricted. So I want to figure out why that's inhibited and what's inhibiting it. And that's where I love the exercise course in complement with muscle energy, because it allows us to look at movement patterns and quickly go, okay, how can I get the biggest, quickest outcome, which is by, treating those areas that are going to influence that inhibition or that tone. And then I love to, use the Neubie right after, because it then just reintegrates that movement pattern.
Thank you so much for listening to the Undercurrent podcast. If you're interested in learning more about how NeuFit and the Neubie can impact your life, please visit our website at www.neu.fit, that's neu.fit, so you can learn more about how it might integrate into your professional practice, how you can use it as a patient, and you can also connect with our team there.
All right, now our next clip is going to be from episode 45 with Jackie Broering, who is another physical therapist who has a practice in rural Ohio. And she talks in this episode a lot about how within that community, they're seeing everything from everyone from the high school football team to the farmers who have had accidents and had limbs amputated and are working on phantom limb pain. And here there's just a fascinating story that she shares about working with one of her son's classmates who was diagnosed with a very rare neurodegenerative condition called AFM, or acute flaccid myelitis. And some of her work with this community, especially with children here, has been very inspiring. And I'm excited to have her share that story with you next. So here's our clip from episode 45 with Jackie Broering.
Actually, it'll be 3 years ago in August. One of our local kids, he was diagnosed later on, we found out, was AFM, or acute flaccid myelitis. And at the time that he was diagnosed, he came down with a virus, was eventually at Dayton Children's Hospital. And after a week or two that he was in the hospital, he was released. And the parents are like, what do we do? Like, what do we do with this kid who is in a wheelchair, has no head support, can't move his arms or his legs? So I took his 70-pound body out of a wheelchair, laid him on a mat table. And so I'm working with him. And actually, he was kind of like the whole spark of the need of getting the Neubie, because you were treating this kid with an unknown diagnosis. They thought maybe virus, maybe, not for sure at the time. And he's in my son's class. So it's like my son and they played soccer together. I've known this kid since, he's 4 years old. And so it was that, like, I've got to do something else. What else can be done? When we had Lucas, that he came in and we treated him with the Neubie, that was kind of like the start of, we did a Facebook post on our Facebook page about Lucas's success. And people with AFM, they're desperate. There's not a lot of there's not a lot of treatment options that really help these kids regain their motor function back. And with Lucas, when he first came in, he was, 70 pounds in a wheelchair. And now here he is, 17 years old, driving a car. He's running cross country. He still has a little bit of, difficulty with head control, but amazingly exceeding my expectations in the amount of time that we have seen him.
So how long did you start with him? He's 17 now. You started with him when he was what, 13?
We started with him. It'll be 2000, I guess 3.5 years ago. I think 2018, 18, 19. I'll have to look. But yeah, his gains have been where we picked him up out of a wheelchair and he had no head control to now full range of motion. And, in both arms, he's running, he's hitting his PR in cross country. So it's so much more than, like, to me, it's that when you have patients, or actually when you have parents say that for the first time that I get to be a parent again and not a caregiver, that's the stuff that it aligns with your heart. You're doing the right thing.
I hope you found that story as inspiring as I do. And now, after going into a couple specific areas of treatment, we're going to zoom back out and talk big picture again. In this clip, it's from episode 76 with Alex Lee, who's a chiropractor with a wonderful clinic in Sarasota, Florida. And I love the way that he talks about big picture, his entire scope of assessment, from more passive chiropractic assessments through active assessments with greater levels of challenge that get into the realm of sports performance too. So we're going to zoom back out and then go along the continuum of care more towards performance. I hope you enjoy this clip. Next is from episode 76 with Dr. Alex Lee.
We have a chiropractic assessment that everybody will go through. So we have a couple different functional nervous system scans. So spinal thermography, so measuring inflammation along the spine, spinal EMG, which is measuring basically muscular tension, and also a heart rate variability scan. So it gives us just a pretty good functional look of what's going on in the nervous system, and then a pretty standard chiropractic analysis. And then after that, what we have is, rather than just being able to see somebody kind of at rest, you can kind of break it up in your head this way. Like the chiropractic assessment is somebody at rest, and then the strength and the movement evaluation would be somebody like under some sort of physical stress. And obviously there's emotional stress and other things that kind of come into that too when there's the physical part. But yeah, we have a few different things that we look at. If we're looking at somebody who has some sort of limitations, like I had kind of mentioned before, then what we're probably going to do is do just the mapping process with the Neubie. And then from there, we're looking at like, what's the biggest imposed limitation or perceived threat that the nervous system has surrounding different movement. So, as an example, we have a lot of baseball pitchers that come in. If we're looking for something where they're saying, hey, like recovery is not as good after starts, or, I have some sort of shoulder or elbow pain when I'm throwing, then, on top of what we're going to do with chiropractic, we're also going to look at what could be some of the guarding and protective mechanisms around that throwing motion and muscles that are either shut off or stuck in like that on mode all the time. That's not allowing them to be able to throw a baseball and absorb force and absorb shock with every single muscle that's supposed to work in that chain, in that, 10th of a second of when they release the ball. So there's that component. And then, I'd also mentioned once there's like no limitations on somebody and things are good. I think where people stand to benefit the most is through just the training approach, which can be done either with the Neubie or without the Neubie. So, a lot of long duration isometric holds, a lot of high repetition, either no weight or low weight. So doing, different things like rebounds and drops, and, just really being able to master, moving with the body weight and before loading and adding complexity through external stimulus. So whether that be weight or just well, I guess traditionally people would think of loading it up with like a barbell. But yeah, I'd say kind of to come back to the philosophy thing that you were talking about before, the biggest thing is we're really focused on what what the software is functioning like rather than the hardware. So software would be just how we're wired, how brain connects to every part of the body and specifically to skeletal muscle through movement. So if we can find a limitation that's really holding somebody back in a certain way, we can make huge changes. I mean, I've done a couple trade shows with you now, and we'll do demos with people, and in 4 or 5 minutes we can get somebody who's had an issue that's been going on for months or years or decades and be able to make like a huge change in a really, really short amount of time. So when we can get somebody to really feel the difference and to feel something unlocked that had been stuck, it's usually not a situation where we see like huge muscle atrophy from one side compared to the other. We're just trying to tap into the potential reservoir of strength that's already there and reconnect that muscle to the brain and reconnect that movement pattern in a clear way. So, to make it simple, if somebody's got something going on in the shoulder, we'll find what the weak points are and then put a ball in their hand and say, okay, go through a throwing motion and go through any motion that would feel kind of sticky or, just not as smooth as it should be. And then have them work through that. And what's cool is that you get to see people like actively relearn and re-engage a movement pattern. I kind of compare it to, watching a toddler learn how to walk, and get upright on their feet. They're literally retraining a movement pattern that they've lost the ability to use right in front of you in, 5 to 15 minutes.
And that brings us to our final clip. So Alex was talking about that continuum of care, getting into training at some point, and we're going to end this episode with a more training-oriented clip. And this is from back in episode 27 with Brad Rowe. Brad himself was a professional bodybuilder competing in Mr. Olympia and became a trainer and was our collaborator on the hypertrophy course that we have in our NeuFit continuing education curriculum. And earlier on in this episode, he told his story of his first experience with the Neubie, where he tore his bicep tendon, had to get surgery. He wasn't supposed to be able to start training his bicep again for 16 weeks, but because of the Neubie, he was able to recover, start training at 8 weeks, and at 14 weeks, so again, 2 weeks before he was even supposed to be training again, at 14 weeks, he went out and placed in a professional bodybuilding competition. So it was this amazing story. And now in this clip, he talks about the work that he did with Dexter Jackson. So we've made our way through, assessment, looking at the nervous system and how it controls movement, injury, influences recovery. And now we're going to talk about a more training-oriented application here as Brad shares his experience with Dexter Jackson, who won Mr. Olympia in 2008. And then Brad will tell you, he had this amazing comeback, came out and placed 4th in Mr. Olympia when he was 49 or 50 years old. And it's an amazing story. I'll let Brad share it here.
Speaking of avoiding early retirement, that's a good segue into, you mentioned Dexter. So let's talk about Dexter Jackson, who won Mr. Olympia in 2008.
Yes.
And competed in how many Mr. Olympias?
He hit 20 Mr. Olympias.
20 Mr. Olympias.
That is absolutely unheard of. It will never be accomplished again. He is just an absolute icon in the sport.
Yes. And can you talk about your experience working with him?
So, Dexter, when we started working together, Dexter was a little older. And as we know that as we get older, the first things that go is our legs. Neurologically, we start having a lot of impedances because we have compression issues in our spine and our hips and things like that. So neurologically, things aren't firing efficiently in the legs. And you'll see that as athletes get older, their legs get a little smaller, a little softer, a little less detail. And Dexter was struggling with that. He was on the brink of being forced into retirement because his legs were extremely subpar. So I was on his case a little bit, like, hey, just give me a shot. Let me get you on the workout once. So we got one quad workout in, and he was blown away at how sore he was for the little amount of work that he did. And but Dexter was kind of a tough one to crack because he absolutely hates the feeling of the Neubie. Mm-hmm. Well, at first, it's a strong vibration. It's not painful whatsoever, but some people just don't like that feeling. And so he hated training on the Neubie, but liked kind of potentially what he saw. So going into the Olympia in 2019, he said, all right, I want to hire you to come train me just once a week on quads. So he was still being trained by Charles Glass. So I would just join the session in, I would hook him up, and I would let Charles run the session. Charles is the head trainer. I'm just there. Obviously at first I had to dictate to Charles, how much volume we were doing and how hard we were pushing it, because, as you know, there's a ramp up phase and you just can't do what you normally do right out of the gate. So Charles at least trusted me through that process of hey, we're only working at 60% this week and the slow ramp up phase. So we got in, I believe it was 16 quad sessions before the Olympia. And
once a week, just one a week, yeah.
Once a week. Mm-hmm. I think we were at like 14 sessions actually. And I can send you the photo so you can pop in here, but the changes to Dexter's legs were just absolutely out of this world phenomenal. Like, there's no way a 49-year-old man improves his legs that much in such a short period of time. And it was
changing no other variables.
Right, dude. And it was the talk of the town. And on top of that, Dexter had suffered from a lot of knee pain. Leg training was very difficult. I mean, I had to wrap his knees all the time and just suffered with severe pain days on end after training. And he wasn't feeling any pain whatsoever. It was the first time in 10 plus years that he wasn't dealing with debilitating knee pain because of training with the Neubie. Our loads were a little lighter at first. I mean, he ended up working up to a place where he was at pretty much full load, but everything's firing efficiently. So, you're having proper displacement of that load, instead of when things aren't firing efficiently, you're having displacement on certain parts of your knee, which is going to cause more wear and tear and more inflammation. So things were firing more efficiently, which was, putting that load throughout the entire leg and not focus so much on the knee. And so from not only from a physique standpoint, but from a quality of life standpoint, he was so blown away.
All right. I hope you enjoyed those clips. Looking back at 100 episodes, one thing is clear. The nervous system is at the heart of everything we do, whether we're talking about neuroplasticity, biomechanics, even muscle hypertrophy. Of course, it's related to recovery and how effectively we recover from workouts, from injuries. And I think it's becoming clear that targeting the nervous system directly leads to better outcomes. So I'm really grateful to all of you for being on this journey with us and for tuning in to this episode 100, part 1. As I mentioned before, in part 2, we'll go ahead and look at these insights and highlights more related to business practices. And then again, in part 3, we'll do the same with insights related to personal development, mindset, and leadership. So if this episode gave you any new ideas or insights, I'd love to hear from you. Please DM on Instagram, drop a comment underneath the episode here. And thank you again for being a part of this journey.